Hello and welcome everyone. Today we will talk about surfactant administration in extreme preterm babies, when to give surfactant, how to give surfactant, what are the evidences for surfactant administration in extreme preterm babies. So next 30 minutes we will be talking about which surfactant should be given in preterm babies, what are the different types of surfactant are available, what is the mechanism of surfactant, when to give and how to give, what are the different methods of surfactant administration, and what are the advantages and disadvantages, what are the evidence. We'll see some landmark trials for surfactant administration. So first, surfactant, different types of surfactant. So two types of surfactant are available. One is natural surfactant, second is synthetic surfactant. Okay, so natural surfactant are two types, minced lung and lung lavage. So they are extracted by minced lung or lung lavage method. Minced lung or surfactant also are two types, bovine based or porcine based. Bovine based surfactant is beractant surfactant and brand name is Survanta. Brand name is available is Survanta. Porcine surfactant is poractant surfactant. Brand name is the curosurf. So these two types of minced surfactant are there, bovine and porcine, beractant and poractant. Second, lung lavage based surfactant is bovine, is BLES, is commonly available. Neosurf is bovine based surfactant and lung lavage extracted. Other one is Cafactant, Infasurf, and Aliofact. So these are the all are the animal derived natural surfactants. Second type is synthetic surfactant. So synthetic only protein based surfactant are recommended. So in protein based synthetic surfactant are second or third generation. In second generation is Lucinectant, that is the surfactant B analog. So surfactant B analog is Lucinectant, that is second generation protein based synthetic surfactant. Second is protein C analog, recombinant surfactant protein C, venticute. And third generation is the surfactant B or surfactant protein C enriched surfactant are third generation. These are protein-based synthetic surfactants. So currently recommended are commonly used are natural and animal-derived surfactant that are derived from bovine or porcine. So commonly available surfactant are survanta, neosurf or curosurf. Doses are survanta is 4 ml per kg. Phospholipid dose is 100 milligram per kg. Survanta dose is 4 ml per kg or 100 milligram per kg of phospholipid. Available vials 4 ml and 8 ml. Neosurf dose is 5 ml per kg. Phospholipid dose is 135 milligram per kg. Available vials are 3 ml and 5 ml. Curosurf is dose is 2.5 ml per kg and recommended dose is 200 milligram per kg. Here 100 milligram per kg also can give, but 200 milligram per kg doses results are better with 200 milligram per kg. Available is 1.5 ml and 3 ml. So which surfactant should be given? What are the recommendations of the different bodies? So European guidelines says that natural surfactant should be used, natural or animal derived surfactant should be used. And they are recommending poractant alpha and dose is 200 milligram per kg. That is the recommendation by European guidelines. Second recommendation by AAP, American Academy of Pediatrics, recommends natural or protein containing synthetic surfactant can be used. WHO also recommends natural surfactant or protein containing synthetic surfactant. So currently we are using natural and animal derived surfactant most commonly used. Coming to what is the mechanism of the surfactant, how they act, how they improve the oxygenation and ventilation, how they cause expansion of the lungs and ventilation. So first is the in alveoli, there is the surface tension. Because of the surface tension inside the alveoli, because of the surface tension of the fluid molecules, there is the tendency of collapse. Alveoli collapse tendency will be there. So surfactant reduces this surface tension, but because in preterm babies there is the deficiency of this surfactant, that's why alveoli will be collapsed. Because of this deficiency of surfactant, there will be increased surface tension and there will be collapse of alveoli. So by surfactant administration, we are reducing this surface tension and we are keeping alveoli open. So this will prevent collapse of alveoli. So maintains the FRC. FRC is the functional residual capacity. So lung volume after expiration is called functional residual capacity, and that will be maintained if alveoli are opened. And this will decrease the VQ, ventilation perfusion mismatch. Because of the expansion of alveoli, opening of alveoli, there will be decrease in the ventilation perfusion mismatch or improved ventilation perfusion matching. This will improve gas exchange, improve the compliance, because after when FRC improves, compliance also improves. And this will decrease the work of breathing also and reduces the pulmonary pressures also. So these so many mechanisms are there of surfactant. Mainly they reduce the surface tension, prevent the collapse of alveoli. That's why maintains the FRC, improve the VQ mismatch, improve the gas exchange. Because of improved FRC, they improve the compliance and decreases the work of breathing and reduces pulmonary pressures also. Here in X-ray we can see this is the before surfactant, this is after surfactant. Before surfactant lung volume are low volume lungs, and there is reticulogranular pattern is there. So reticulogranular patterns happen because of collapse of alveoli. Granules are appear. Granules are appear because of collapse of alveoli. Reticular patterns appears because the terminal bronchioles will be visible as a reticular against the collapse parenchyma, and this larger airways will be visible as a air bronchogram. So larger airways against the background of the collapse alveoli will be visible as a air bronchogram. So these X-ray features of RDS: low volume lung, reticulogranular or ground glass appearance, air bronchogram. These are the features of RDS. But after surfactant, lung expansion improves, lung volume has improved. There is an aeration is improved. There is no reticulogranular pattern after surfactant administration. So here we can understand the mechanisms. This one is the with surfactant, this is without surfactant. So this one is the alveoli. In alveoli, because of the surface tension between the molecules, there will be collapse of the alveoli. Okay, and pressure requirement to keep open the alveoli will be higher. Here, pressure requirement to keep alveoli open will be higher. But after surfactant administration, this surface tension will be reduced, and this tendency of alveoli to collapse will be reduced, and pressure required to keep alveoli open will be reduced. So here pressure requirement is less, here pressure requirement is high. Here surfactant film is there that will reduce the surface tension and keep alveoli open by reducing surface tension. Second, by Laplace law, second method to keep alveoli open is by pressure or increasing the radius of the alveoli. If we increase the radius of alveoli, then pressure required to keep alveoli open will be reduced by Laplace law. So pressure required to keep alveoli open is directly proportional to the surface tension and inversely proportional to the radius. If we increase the radius by giving pressure, then pressure required to keep alveoli will be reduced. So here alveoli was collapsed, radius was less, but here we are giving pressure and keeping alveoli open. When alveoli has opened once, then pressure required to keep alveoli open will be less. So this we are doing by CPAP. This we are doing by surfactant. So surfactant and CPAP both are helping to keep alveoli open, to keep maintain the FRC. So this is the mechanism of surfactant and CPAP. Okay. Here we can see FRC and compliance. So by PV loop, we can see initially when lungs are collapsed, alveoli are collapsed, FRC is very low. When lungs are expanding, here we can see that FRC is optimal here in the up to this. FRC is optimal. When FRC is optimal, then compliance also will be maximum. So per unit change in the pressure, change volume will be maximum here. So FRC is optimal here and compliance also will be maximum. So steeper the curve, compliance will be more. This compliance is less, this one is more. But if we expand more, if there is over expansion, then also compliance will be reduced. So if lungs are atelectasis is there, compliance will be less. If over expanded, compliance will be less. Here is the optimal compliance, optimal FRC is there. So we want to work here. We want to keep lungs open. We want to keep FRC optimal and compliance maximum. Here in PV loop, we can see before surfactant, this compliance is very less. This compliance is very less. More horizontal the curve, less is the compliance. More vertical is the curve, more the compliance. So after giving surfactant, this PV loop has become more vertical. Compliance has improved of the lungs. Now we will see about what is VQ mismatch. So VQ mismatch, V for ventilation, Q for perfusion. So here we can see this is the alveoli, this is the alveoli, and this is the pulmonary capillary. This is the pulmonary capillary. So inside the lung, there will be gas exchange between the alveoli and pulmonary capillaries. This is the perfusion, this is the ventilation. So here we can see that alveoli is collapsed. So in RDS, alveoli in preterm babies, alveoli is collapsed, but perfusion is normal. Pulmonary capillaries perfusion are normal, but alveoli is collapsed. So what will be the VQ? VQ will be less than 1 because ventilation is the poor, perfusion is normal. So there will be the low VQ. When ventilation perfusion mismatch is there. Ventilation is not there, but perfusion is there. That is called ventilation perfusion mismatch. Okay, so here what will happen? Here that blood will go without oxygenation. This is we called left. This is called right to left shunt, right to left shunt or intrapulmonary shunting. This we call intrapulmonary shunting or shunt perfusion. So intrapulmonary shunting will happen and baby will be in hypoxia. So here we have to recruit the alveoli. We have to recruit the alveoli by CPAP or ventilation. We have to open the alveoli. After opening up, what will happen? Here we can see here if alveoli is opened, perfusion also is good. Perfusion is good. So ventilation and perfusion both are equal. So ventilation perfusion is matching. So ratio will be 1. So here ventilation also is good, perfusion also is good. There will be the good exchange. There will be good gas exchange. This is the complete normal for situation. If there is third situation is there, that alveoli is open. Here alveoli is open, but pulmonary capillary is vasoconstricted. Because increase of pulmonary vascular resistance, pulmonary vasoconstriction is there. This happens in PPHN. So in PPHN, what is happening? That pulmonary vasoconstriction will be there, but ventilation is good. So here what will happen? VQ mismatch will be more than 1. So ventilation is there, but perfusion is poor. So VQ mismatch will be there and VQ ratio will be more than 1. So here still gas exchange will not happen because perfusion is not happening. So here we have to open the pulmonary vasculature. For that we have to give pulmonary vasodilators, sildenafil, nitric oxide. So this is we call dead space ventilation in PPHN. This is we call intrapulmonary shunting, that is in RDS. This one is the normal situation, proper matching of the ventilation perfusion. Coming to timing, this we have discussed in last lecture also. So we'll discuss briefly. So prophylactic surfactant, if you give before developing symptoms, that is not recommended nowadays. Early rescue surfactant if you give within 2 hours and after developing the respiratory distress. And this is the recommended early rescues within 2 hours. Late rescue we can give in outborn babies, but early rescue is recommended. European consensus guidelines, they say that what is the indication of the surfactant? If any baby is having FI2 requirement more than 30% with CPAP of 6 centimeter of S2O, that is the indication of surfactant administration. Or if any baby requiring intubation for stabilization, then also we can give. Early rescue is recommended according to European guidelines, and animal-derived surfactant should be given. European guidelines say that 200 milligram per kg of poractant alpha means curosurf. Curosurf 200 milligram per kg is better than 100 milligram per kg of curosurf or beractant also. So they are telling that curosurf is better than this survanta or neosurf in efficacy according to European guidelines. And European guidelines say LISA should be preferred method of the surfactant administration if baby is spontaneously breathing and baby is on CPAP, baby is having good spontaneous respiratory efforts, then LISA method should be preferred in preterm babies. Or laryngeal mask also can be used if baby is more than 1 kg. Repeat dose we can give. Still persistent features of RDS. FI2 requirement is still more than 30%. Or still babies needing mechanical ventilation. We should follow low threshold only for surfactant administration. So in this condition we can give. Or after how much time? In curosurf we can give after 12 hours. Survanta after 6 hours. So curosurf we can wait up to 12 hours and then we can repeat. Maximum 3 doses are recommended for repeat dose of surfactant. Methods also we have discussed in last lecture. So INSURE method, in Rexure, LISA, LMA, Nebulised or Nasopharyngeal. Most commonly used is INSURE. In Rexure is not using because it's an invasive method. LISA is most commonly recommended method for preterm babies. LMA also currently is not recommended. Nebulization also is not recommended. Nasopharyngeal also currently not recommended. So currently recommended for extreme preterm babies, LISA is the best method, or we can use INSURE also. So these commonly recommended methods are there. So INSURE method we have discussed in last lecture. LISA method. In LISA, no intubation is required. Continue baby on CPAP. Baby is spontaneously breathing on CPAP. Insert the catheter directly under the vision with laryngoscope by surfcath, angiocath, or simple feeding tube. Also, we can administer directly under the vision with the help of laryngoscopy, and we can insert with the Megel's forceps. Also, we can insert this catheter and administer surfactant with continue of CPAP. This is the method of less invasive surfactant administered, LISA or MIST. So in LISA method, we are using Megel's forceps under the direct laryngoscopy. MIST, we are using stiff catheter without Megel's forceps. That is some difference in the LISA or MIST. Both are similar only. And CPAP to continue for alveolar recruitment. So in CPAP, we are continuing to recruit, keep alveoli open. So if we remove the CPAP, alveoli will be collapsed, then surfactant will not spread homogeneously. So continue CPAP and give surfactant under direct laryngoscopy. Here we need trained personnel because person should be trained so that should not go in the esophagus. Here some risk of spillage will be there. So we can use curosurf because here quantity will be less, 2.5 ml per kg. So spillage risk will be less. LMA we can use more than 1 kg or more than 1.5 kg babies because it's slightly non-invasive method, but it's not routinely recommended. Risk of the reflux will be there, coughing will be there. Okay, sometimes we can use if there is difficulty in intubation. Difficult intubation situations we can use. Nebulized surfactant is delivered by vibrating mesh nebulizers. Here also some problem is there. Inactivation of surfactant will be there. Non-homogeneous distribution will be there. Loss of surfactant in upper airway and esophagus will be there. So still, this is not recommended. Nasopharyngeal also, they tried before first breathe of the baby, immediately after you put the surfactant in nasopharynx, that will be spread, aspirated into the fluid-filled airways, but currently not recommended. Now we'll discuss some landmark trials about evidences about surfactant administration in preterm babies. So this is the systematic review or meta-analysis. They have included 6 RCTs and they compared LISA versus INSURE method. So in this meta-analysis, they have compared LISA versus intubation methods, and they found that LISA method reduces need of mechanical ventilation. Okay, 6 RCTs they have included, and they found that reduces need of mechanical ventilation and reduces composite outcome of death and BPD. So LISA method is preferred in preterm babies because of reduced risk of BPD, death, and need of mechanical ventilation, according to this meta-analysis. Second is the Take Care trial. Take Care trial, they have compared LISA versus INSURE, less than 32-weeker babies. And they have started delivery room CPAP or intubate and surfactant. In that, they have used curosurf 100 milligram per kg. In this, they have found that in LISA method, reduces need of intubation, reduces duration of ventilation, reduces risk of the BPD. Yes. So still, this Take Care trial also favors LISA method in preterm babies, less than 32-weeker babies, reduces need of ventilation, duration of ventilation, and reduces BPD. Next is AMV trial. AMV trial is avoidance of mechanical ventilation trial. In this, they have compared the LISA versus standard treatment in less than 28-weeker extreme preterm babies. In this also, they have found reduces need of mechanical ventilation, duration of ventilation, and oxygen requirement 28 days. Means BPD also reduced. So same, they have found that they reduces BPD also, but no difference in mortality, according to AMV trial, avoidance of mechanical ventilation trial. Next is NINSAPP trial. NINSAPP trial is non-intubated surfactant application. Non-intubated surfactant trial. So this NINSAPP trial is slightly different. They have found the result was different from the other trials. They found that did not increase survival without BPD. So in this, they have found they have no effect on BPD, but reduces need of intubation, reduces duration of ventilation, and reduces risk of pneumothorax and IVH. So other benefits are there about ventilation, intubation, and duration, and complications also, reduces complications also, LISA method. But they did not find reduced risk of BPD in NINSAPP trial. Next is OPTIMIST trial. OPTIMIST trial also, they have included extreme preterm babies less than 28-weeker, and they've compared LISA versus conventional method, and they've used 200 milligram per kg of curosurf. In this, they have found reduced BPD in mixed group. So in this OPTIMIST trial also found incidence of BPD was lower in mixed group. Okay. Next is CureNeb trial. CureNeb trial, they have compared nebulized surfactant. They have studied nebulized surfactant to reduce severity of respiratory distress. So they have included babies less than 33 weeks of gestation and CPAP alone or CPAP with nebulized surfactant curosurf 200 milligram per kg. They have delivered by nebulization method. Vibrating mesh nebulizer they have used. In this, they have found that reduces need of intubation within 72 hours. So nebulized surfactant CureNeb trial found that reduces risk of need of intubation within 3 days of birth. But still, this is not a common practice, nebulized surfactant. More trials are required on this. Next is Sunset trial. Sunset trial in the prophylactic surfactant nebulization for aeration of the preterm lung. In this, they have recruited less than 32-weeker babies, and they have compared CPAP versus CPAP and surfactant nebulization in delivery room itself. In delivery room, prophylactically, they have nebulized with surfactant, and they have nebulized with 200 milligram per kg of curosurf, and they have studied end expiratory lung impedance. This is the marker of lung aeration or lung expansion. End expiratory lung impedance. If lung impedance increases, means lung aeration also is increasing. So in this, they have found that prophylactic surfactant nebulization did not improve lung aeration or lung expansion. So in this, they have did not find any benefit of prophylactic surfactant nebulization, and currently this is not recommended in Sunset study group. One more, this trial was done. In this, they have given intratracheal administration of budesonide plus surfactant. Budesonide and surfactant, they have administration to prevent BPD. So 100 milligram per kg of surfactant and 0.25 milligram per kg budesonide versus surfactant. So they have compared surfactant plus budesonide or surfactant only. And they have found that decreased incidence of BPD or death. Okay. So budesonide they have included, and they found that decreased incidence of BPD or death in budesonide group. Next, in INREXSURE trial. In INREXSURE trial, lung recruitment was done before surfactant administration by HFO. So they have included extreme preterm babies less than 28 weeks, and they have divided in two groups. One in INREXSURE, second in INSURE. In INREXSURE group, they have recruited lungs by HFO, followed by surfactant. INSURE, they have intubated, given surfactant without recruiting. And they found that in INREXSURE trial reduces need of intubation for 72 hours, but no effect on mortality, no effect on other complication, only reduces need of the intubation in first 72 hours in INREXSURE trial. But currently it is not commonly practiced because this one is an invasive method. We have to intubate the baby, put on HFO, then we have to recruit. So we have to go toward the non-invasive method. That's why commonly not recommended. Now coming to Cochrane meta-analysis. So Cochrane meta-analysis included 16 studies, 16 trials that compared LISA versus intubation methods. And they have found, Cochrane finally found that LISA method reduces risk of the BPD, reduces mortality, reduces need of intubation, reduces duration of mechanical ventilation, and reduces other major complications like pneumothorax, IVH. So many benefits are there according to Cochrane meta-analysis. So in preterm babies, LISA or minced method is the best method, evidence-based method. We should practice this only in extreme preterm babies. So recommendations, European Society recommend strong recommendation with high quality evidence on LISA method. Canadian Society also recommends LISA method. NHS also recommends LISA methods. NNF CPG guidelines with moderate evidence, they also recommend LISA methods. So prophylactic or selective, we should go for selective. We should go early rescue with INSURE or LISA, definitely LISA method. Natural surfactant, currently natural only recommended. Multiple doses we can give, and we should follow low threshold for surfactant administration. So in this, we have discussed everything about surfactant administration in preterm babies. We have discussed only the practical points, what should we follow, and what are the evidences, what are the landmark trials on this. Thank you so much.